Okay, so we have here the overview of our anemia. We have here the functional definition of our anemia. So this is just a decrease in the oxygen carrying capacity. So basically that one will be highly related to your hemoglobin concentration. So we tend to diagnose someone to have anemia based on the values of your hemoglobin. Okay, so if the result of the patient's hemoglobin here is less than the normal values, then we consider that one as anemia. We are not using the value of your hematocrit as a basis for classifying our patient for the anemia. But rather, we are using the value of your hematocrit for the diagnosis of your polycythemia, mga ganon, but not for the related to your hemoglobin concentration or not directly related for you to classify that one as the having an anemia. Okay, we have here the different mechanism of our anemia. So pag sinabing anemia, just here the blood loss. Okay, so you could have here anemia because of problem in the RBC production, or you have also anemia because also of the problem in the RBC destruction. So anemia may occur here if even you have your normal na RBC production, normal na RBC destruction, but the patient hemoglobin value is decreased, and that would be related here to the blood loss. So baka meron siyang sugat or anything like that that would eventually result to your anemia. Okay, but normal ang kanyang bone marrow production ng mga blood cells natin. Hindi naman nag-increase ang red cell destruction, so therefore that will be related here to your blood loss. Anemia also being diagnosed if you have here decreased production of our RBC with our bone marrow. So normal destruction, so that would signify the patient would have here the aplastic anemia. Anemia is also diagnosed if the patients would have a normal RBC production, normal ang pag-produce ni bone marrow ng mga RBC, pero namamatay sila agad because of increased destruction, and that's related to your hemolytic reactions. Then we have also here, mababa ang production, sobrang increase ang destruction. So, I mean to say the RBC is being eliminated in the peripheral circulation, blood circulation, earlier than their expected na lifespan. So, hindi pa sila na-reach ang 120 days. Pinatay na sila. Tapos increased destruction. So, that will be related to your drug-associated mga hemolytic anemia. These are hemolytic anemia, mga autoimmune hemolytic anemia. Okay, we have here the classification of our anemia according to the cause of the abnormality according to Brown classification. The first one, the patient would have anemia because of the decreased RBC production, maybe because of decreased bone marrow production. Second one, decrease ang ating RBC production because you are not producing erythropoietin. Remember that your erythropoietin is the hormone produced by our kidney that try to stimulate our RBC production. Another one could also be related to your iron deficiency. Okay, anemia is also could be related to the problem in the nuclear maturation of our RBC, just in the case of your vitamin B12 deficiency anemia. Example for that is your folic acid deficiency anemia. Vitamin B12 deficiency anemia related to your folic acid, related to your intrinsic factor deficiency that would eventually result to your pernicious anemia. So pernicious anemia is actually a type of your vitamin B12 deficiency anemia. Folic acid deficiency anemia also affects here the nuclear maturation process, or even in your refractory anemia in the case of your Digo-Guglielmo syndrome or Digo-Guglielmo's anemia. Another one, you could also have anemia because of the problem in the cytoplasm of the RBC related to number one, severe iron deficiency, problem in your globin strain production, which is a quantitative defects in the form of your thalassemia. And we have also here the defective na heme synthesis because of your, in the case of your sideroblastic anemia. And lastly, you could also have classified our anemia as hemolytic anemia. Hemolytic anemia, okay, so in the absence of the blood loss, wala kang physical na blood loss nakita, naging anemic ang patient, so we are suspecting that the patient is suffering with your hemolytic anemia. Okay, we classify that one as acute related to your hemorrhage or chronic may be related to your RBC membrane defects. So that may be in the form of your hereditary spherocytosis, hereditary eleptocytosis, or it might also be related to your enzyme defect like your leuco-6 phosphate dehydrogenase deficiency, or even with your pyruvate kinase deficiency. Or it could also be related to your hemoglobinopathies, just in the case of your hemoglobin S, hemoglobin C. Your thalassemia is considered as a quantitative globin chain defect. Ito naman is your hemoglobinopathies is just a qualitative na globin chain defect. Okay, so we have here the classification of our anemia. So we're using here the different blood indices in order for us to diagnose someone to have here the classification of our anemia. So the first one, we have the MCV. So again, the MCV, normal values for that is 80 to 100 ml. So it would classify the anemia according to the size, diba? CT, normal, CT, macrocytic, and we have also here your microcytic. And we have also your MCAC, 31 to 36 grams per DL, or could have your 32 grams per DL. Okay, that would have your decreased result. That's your hypochromic, di ba? Increase more than 36 is more of that one is your hyperchromic. So, normochromic pag normal. So, we start here with your macrocytic hyperchromic anemia. The first one, we have your vitamin B12 deficiency anemia. Vitamin B12 deficiency anemia could be caused here by sprue. Pwede rin siyang gastrectomy or even your dilatum infection. It could also have here your pernicious anemia. So any of the following here try to cause your vitamin B12 deficiency anemia. As the structure of the vitamin B12 so it's made up of your 5,6 dimethyl benzimidazole, made up of the pyrrole ring, and we have also here the cobalt atom. Okay, so vitamin B12 is needed for the DNA synthesis. That's why pag may problem with your vitamin B12, it that result here to your nuclear maturation defects. It's because again, vitamin B12 is needed to convert your deoxyribose to your ribose nucleotide to your deoxyribonucleotide for your DNA synthesis. Okay, we have here the sources of your vitamin B12. So, usually vitamin B12 is being produced by animals. It could also be synthesized by your microorganism, like for example, your Propionibacterium shermanii. Could also have here your Streptomyces gracious. Laboratory findings. So, this lab result here most likely not only to your vitamin B12 but as well as to all our macrocytic anemia. So, hematological, we have increased macrocellularity, kaya macrocytic. Then we have also here the presence of your hypersegmented neutrophil. So again, hypersegmented neutrophil having more than 5 na lobes. Usually kasi that's 2 to 5 lobes lang ang ating neutrophil. Pag more than 5, it becomes your hypersegmented neutrophil. Then we have also here your Howell Jolly bodies, which is one of your inclusion bodies related to your megaloblastic anemia and macrovalicites, sobrang laki ng size ng ating RBC. Non-hematological, you could perform here gastric acid juice or gastric analysis here, characterized by the absence of your hydrochloric acid, that's your achlorhydria. And we have also here decreased na serum vitamin B12. Okay, then we have here your pernicious anemia. So, pernicious anemia, other name for that is your Burner's disease or your intrinsic factor deficiency anemia. Intrinsic factor is needed in order for you to allow absorption of your vitamin B12 in the ileum of your small intestine. Pag wala kayong intrinsic factor, that would eventually result sa your vitamin B12 deficiency anemia. Again, your intrinsic factor is needed in order for you to absorb your vitamin B12 in the ileum of your small intestine. So pag wala kayong intrinsic factor, that's your pernicious anemia. Okay, patients with pernicious anemia produces here two types of antibody. Anti-parietal antibody that's directed towards the parietal cells of your stomach. Kaya nga wala kang hydrochloric acid because this antibody try to destroy your parietal cells which try to produce your hydrochloric acid. Usually the patient natin, majority of the patient, 90% would produce this type of the autoantibody. Another one, an anti-IF antibody, anti-intrinsic factor antibodies being produced here by 75% of the patient. It is a type of the antibody that's usually present in the serum, saliva, or even the gastric juice of the patient. So again, there are also two types of antibody. Why it try to prevent the reabsorption of our um, cobalamin, or you call it once, this is your vitamin B12, preventing that one not to be reabsorbed in the ileum of our small intestine. Number one, blocking antibody. The blocking antibody prevent your IF to bind with the cobalamin, and therefore it will not allow the reabsorption of that. On the other hand, we have also here the binding antibody. The binding antibody tends to bind with your cobalamin IF complex. Makaka-form ka ng cobalamin IF complex, however, still, it will prevent pa rin niya ang pag-bind ng ating complex to your ileum for the reabsorption of your cobalamin or vitamin B12. In the end, ang pinaka-effect niya, still, hindi pa rin ma-reabsorb ang ating vitamin B12, and therefore that's result here with to your vitamin B12 deficiency anemia. And then we have here different laboratory tests that would help us then to diagnose patient na may vitamin B12. The first one, you could use your microbiological assay with the use of your bacteria which try to synthesize vitamin B12. So pag ganito bacteria mo, sa pag mababa ang activity mo or result mo, so it will signify that the patient would have vitamin B12 deficiency. So sample for that, we have your Clinogracillus and we have your Lactobacillus leishmani. Another one, we could also perform here the radioactive Schilling's test by the use of your cobalt radioactive substance in the form of cobalt-60. So radioactive siya, nililabel natin para ma-measure natin ang activity ng cobalt-60 in our body. So kaya mo bang i-excrete ang cobalt-60 or hindi? Okay, so that's your Schilling's test. The first test, bibigyan mo ng radioactive labeled vitamin B12 ang patient natin with the cobalt-60. Then after that one, after 24 hours of administration, try to collect the urine and try to measure the radioactivity. So, pag nalabas niya, like, ang cut-off natin is 7%. Pag ang result mo more than 7%, then that's normal. However, pag mababa doon to 7%, then you need to perform the second Schilling's test. Okay, kasi hindi natin alam kung nagkakos pa ng problem ng vitamin B12 natin is dahil lang sa intrinsic factor pa, or it is either caused here by lysis sprue, gastrectomy, or dilatom ba na try to cause your vitamin B12 deficiency. Para ma-discriminate natin, then you give, in the second Schilling test, you give here your HAG-IF. So, kaling ang IF, intrinsic factor, bigyan mo siya ng intrinsic factor. However, the source of that is hog or sa baboy. Okay, so pag nagbigay ka ng intrinsic factor, pag ang result niya tumaas, so since nagbigay ka ng IF, tumaas siya, mean to say dati, mababang result niya is because kulang siya ng IF. And that's would, pag na-correct na siya after that one, okay, that's your intrinsic factor ang problem ng patient. Pero pag hindi pa rin siya na-correct, even if you give already your HAG-IF, mean to say the problem with your vitamin B12 is not on the intrinsic factor, but rather on other problem. Like, for example, baka doon sa gastrectomy or sprue or dilatum infection. Pag ang second Schilling test mo still abnormal ang result pa din. Another one, we have your indirect methyl malonic acids. These are the products of your defective DNA synthesis. So therefore, pag madami ka niyan, it will signify that the patient would have a vitamin B12, signifying that you have problem with the DNA synthesis. And this one usually being collected urine as our sample. Another one, we have your deoxyuridine suppression test. Again, this is to try to demonstrate your defective the DNA then. Okay, this would also try to assess for the vitamin B12 deficiency anemia. Okay, now we go to your another megaloblastic anemia or macrocytic anemia. So we have your folic acid deficiency anemia. So structurally, your folic acid is your teroyl glutamic acid. Okay, your folic acid is also needed for our DNA synthesis, basically for the methylation process for your thymidylate synthesis. So your folic acid is needed here to undergo methylation of your deoxy. Okay, uridylate to become your deoxythymidylate. That's why it's being utilized primarily for the thymidylate na methylation process. Okay, so we have here the structure of your folic acid. So it's made up of your pteridine ring, para-aminobenzoic acid, and we have also here one of the number of our glutamic acid. So we have here the method for determination of the folic acid deficiency. Number one, you could perform here the serum determination of the metabolites of your folic acid in the form of your tetrahydrofolic acid or folate. Another one, you could also have here your determination of your form glutamic acid. The form glutamic acid, you can convert that one to your uh, 4-aminoglutamic acid to your glutamic acid with the use of your folic acid. So kung wala kang folic acid, you could not convert the figlo, mababang level nito, so that would signify that the patient would have here the folic acid deficiency. Another one, you could also perform your microbiological assay with the use of your Leishmaniac assay. Again, that is the microorganism we try to utilize your folic acid. And lastly, you can also perform the serum determination of the folic acid level in the patient plasma. So again, pag mababang level niya, it would signify that the patient would have here the folic acid deficiency. Okay, then we have here the difference between your vitamin B12 and our folic acid. So number one, sources. Again, your vitamin B12, you can obtain that one from the animal sources. Rich ang mga animal natin ng vitamin B12. The folic acid, on the other hand, could be obtained here from the liver or even your green leafy vegetables. Absorption site, kung saan na-absorb ang ating vitamin B12 is your ileum, the small intestine, and the folic acid will be on the jejunum and the duodenum. And we have also here the absorption mechanism. So for your vitamin B12, it could be only be absorbed here with the help of your intrinsic factor, whereas your folic acid will be absorbed once it's been converted to the absorbable form of your folic acid in the form of your methyl tetrahydrofolate. Once hindi mo siya ma-convert dito, since ito ang absorbable form, pag hindi mo na-convert dito, it will not be reabsorbed. Pag hindi siya ma-absorb, then eventually what you have here will be your folic acid deficiency.